Physiology, Pain Medicine and Critical Care. With me, there's a big team from Pulmonary Medicine Department, and we'll be discussing about how to manage COVID-19 patients if they turn up into ICU. What should be the ventilating management of these patients? At this time, the situation of COVID is not really very good. Globally, there are approximately 4 lakh patients with 18,000 odd deaths, and the level of risk is very high. As per yesterday, approximately 600 something patients were reported in India alone with 12 deaths. So if we talk about the presentation, fever presents in 77 to 98% of the patients, cough in 46 to 82. Actually, the number varies from different studies to different studies. They also present with myalgia, shortness of breath, and some flu-like syndrome. There are certain risk factors like old age, male gender, presence of underlying comorbidities such as diabetes, malignancy, immunocompromised status. They do present with severe symptomatology, and therefore they are associated with critical care unit admission. If you talk about the spectrum of the disease severity, 81% of the patients, they present with non-severe disease. That means the symptoms will be like flu-like syndrome, and approximately 14% of the patients, they present with severe non-critical symptomatology like desaturation, tachypnea, tachycardia. Out of 100%, 5% patients, they present with multi-organ dysfunction, requirement of the mechanical ventilation support. These are the critical patients. And we will be more focused about the management of this 5% subset of the population. If we talk about the mortality in non-severe patient is approximately 0.1%, whereas the mortality in severe patient is around 8%. And in critical patients, it is very, very high. It is 42 to 62% of the patient will die because of their illness, because of multiple organ dysfunction. Overall, the mortality is 2 to 3%. The case fatality that increase with age, patients with more than 60% of the age, they have more chances of mortality as compared to the younger population. In younger population, the mortality is somewhere around 2 to 3%. But in aged population, more than 80 years, the mortality is approximately 15%. If a patient is not having any underlying medical illness, mortality is very, very low. It is around 0.9%. And it shoots to 10% in patient with cardiovascular disease. For diabetes, for chronic respiratory illness, it is also very high. It is 6 to 7%. The major cause of mortality in COVID patient is respiratory failure. Approximately 53% of patients die because of respiratory failure. In approximately 33%, this respiratory failure is with myocardial damage or heart failure. Some 7% of the patients, they develop myocardial damage. Here comes the role of ventilatory settings, ventilator management, because approximately 80 to 85% of the population, they require ventilator support in ICU. And here comes the role of critical care specialists. If we talk about the typical presentation in the first week, the chances of viral shedding is very high. But the symptomatology is not that severe. In the second week, it is very, very severe. Patients land up into respiratory failure, and at times they go into multi-organ dysfunction. In the initial first week illness, the disease is mild, so there is less requirement of the oxygen therapy. High flow nasal cannula requirement may be there, but in the second week, patient tends to go into invasive form of mechanical ventilation. They develop hospital-acquired pneumonia, they develop CRBSI, ventilator-associated pneumonia, ARDS is quite common, and here comes the role of antibiotics and all things which are required in critical care. These patients present with pneumonia as well as ARDS. ARDS, as such, we know that It is known as the presence of new or worsening respiratory symptoms within 7 days of a non-clinical insult with combination of acute hypoxemia, which is defined as PO2 FiO2 ratio of less than 300 mmHg in a ventilated patient with positive end expiratory pressure of at least 5 centimeters of H2O. There is a problem here. To define acute hypoxemia, as per this definition, we need to know about the blood gases, about the PO2 FiO2 ratio, for which we need ABG. But as we all know that ABG is not widely available in our country. This is one of the shortcomings of this definition. The other problem is PEEP. It is at the fixed time. So these are the shortcomings of it. There should be bilateral opacities in the radiograph, which should not be fully explained by heart failure or volume overload. Also, this hypoxemia should not be fully explained with collapse, pleural effusion, or nodules. ARDS is defined as mild, moderate, and severe depending upon the PO2 FiO2 ratio. If the PO2 FiO2 ratio is in between 200 to 300, we say it as mild. Less than 200 but more than 100 is more moderate, and severe if it is less than 100. When we don't have PO2 in our clinical scenario, clinical settings, then we can use SpO2 FiO2 ratio. And SpO2 FiO2 ratio less than 315, such as ARDS. If it is in between 235 to 350, it roughly correlates with PO2 FiO2 ratio of 200 to 300. So in a resource limited setting, we can use SpO2 FiO2 ratio to diagnose and thus to manage ARDS patients. There are many indications of mechanical ventilation in these patients with emergency signs like obstruction, absent breathing, severe respiratory distress, central cyanosis, shock, vasopressors with respiratory distress, coma, convulsions. They all need intubation. And they need intubation because we want to provide certain level of care. We want to achieve adequate ventilation. By putting a patient on mechanical ventilator, we can eliminate carbon dioxide. We can achieve a minute ventilation to take care of the carbon dioxide. We can improve oxygenation by providing positive and expiratory pressure, by providing high amount of FiO2. We do it to relieve respiratory distress. What happens in a patient who is having very high respiratory drive because of pneumonia, because of ARDS? They tend to breathe a lot. There is dead space ventilation, tachypnea is there. So the blood, which was supposed to reach the vital organs, now that will jump and pump into the respiratory muscles. And that will lead to problem. So we want to support the respiratory functions so that the blood supply again can be shunted to the vital organs like brain, kidney, heart, maybe intestine. But in the ideal world, we need to achieve normal PaC2 and pH. What happens in ARDS patient? The lungs are very small. They are kind of baby lungs. The working or aerated zone is small. So if we give high amount of tidal volume, there is going to be ventilator-induced lung injury. So we have to compensate, and we have to be happy with low pH, which here we can see a pH in between 7.25 to 7.35, and high PaCO2. High means, in many studies, it has been proved that if you allow your PaCO2 to jump more than 55, maybe 60, it's going to cause increase in the pulmonary artery pressures. And this will lead to cor pulmonale or right ventricular dysfunction. Again, there will be hemodynamic compromise, and that will create troubles. So if we talk about the understanding of airway pressures, a pressure which is like at the point of mouth opening is peak airway pressures. If you put endotracheal tube, it will be at the Y piece. There will be some pressure inside the lung, and when flows are zero, this is known as plateau pressure or alveolar pressure. There is going to be some pressure in the pleural cavity. What happens in sicker lot? They tend to breathe a lot. They will create a very high amount of negative pressure, and this is the thing which may lead to increase in the transpulmonary pressure. Transpulmonary pressure as such is defined as the alveolar pressure minus pleural pressure. Now patient is breathing spontaneously, this pleural pressure will be negative. say the alveolar pressure is 25 and pleural pressure is 25, minus 25. So what we will do, that 25 alveolar pressure, that is alveolar pressure 25 minus 25. This minus will be positive. So the transpulmonary pressure will be 50, which is way too high, which can cause ventilator-induced lung injury. So what happens when you provide this mechanical ventilation to a patient? With mechanical ventilation will take care of two types of elements. One is resistive work of breathing, the another one is elastic work of breathing. Airway and endotracheal tube, they all contribute to resistive element, which we can calculate by if we multiply flow into resistance. The problem is, if you increase the flow, the resistive element will increase. If we talk about the elastic element, it is because of lungs and chest wall. Now we all know what happens in ARDS patient. There will be some sort of increase in the elasticity or decrease in the compliance, which will lead to stiff lungs. So the work of breathing to take care of elastic work will be very high. Now, a healthy patient, or for this patient, any patient, for this scenario, any patient will work against resistive element and elastic element. And if you put the patient on mechanical ventilation, this PAW, work done to take care of elastic as well as resistive work will be done by patient as well as ventilator. So the ventilator, what it will do, that it will compress some air, and what lungs will do, the diaphragm will work, diaphragm will contract, and it will inflate the lungs. So to synchronize these two mechanics, we have to put something in between the ventilator and airway. This is the endotracheal tube. Okay. So the resistance now is because of airways and because of endotracheal tube. So if we want to decrease the resistance because of endotracheal tube, we should insert an endotracheal tube of largest possible size, the size which patient's trachea can accommodate without any injury. There will be some elastic work, and this elastic work is because of the lungs and chest wall. Now, coming to the mechanical ventilation, the core topic of today's training. Mechanical ventilation may be non-invasive or invasive mechanical ventilation. In non-invasive ventilation, it may be high flow nasal cannula, it may be this helmet, or it may be some non-invasive ventilation by putting a face mask or some nasal mask. We'll be discussing about the utility, about the problems with these devices. So, if you come to the basic settings of mechanical ventilation, you can use whatsoever mode you want to use. You can use BCV, you can use PRVC, you can use PCV. There is no difference in terms of survival, particularly in ARDS patients. It is not about which mode is better or which is worse. It is about the person who is dealing with that mode. How trained you are, how good you are about interpreting patient-ventilator synchrony. So if you can set your flow in some ventilator, you can increase or decrease your flow. In some ventilator, it is fixed, and you can play around with your flows by changing the type of the flow, or by increasing or decreasing the inspiratory time. Conventionally, the flow used in volume control ventilation is constant flow. FiO2, we will discuss about it, how to set FiO2. So the FiO2, when you intubate the trachea in a desaturating patient, in any kind of patient, we start from 100%, and depending upon the clinical condition of the patient, we'll decrease it over the period of 15 minutes to 60 minutes. The FiO2, with which our patient can maintain SpO2 of 92 to 96% is good enough. Then comes tidal volume. So to tidal volume, to set tidal volume, we need to know the predicted body weight of the patient. There is a formula like 50 plus 2.3 bracket height in inches minus 60. Say I'm 5 feet 6 inches. My height is 66 inches. If you subtract 60 out of it, it will be 6. If you multiply 66 with 2.3, it will be somewhere around 13 or 14. So 50 plus 14, it will be around 64. For the sake of ease, we can take it as 65. Then you can keep your tidal volume 6 ml per kg or 8 ml per kg. That means 65 into 6 or 65 into 8. Respiratory rate, we target carbon dioxide, PaCO2 of around 45, 48 in a patient who are having stiff lungs. Otherwise, PaCO2 of 40 is good. So we keep respiratory rate as per the requirement of the patient, as per the pH and as per the PaCO2 of the patient. PEEP is the positive end expiratory pressure. We keep the positive end expiratory pressure to inflate the lung. If you don't give PEEP, what's going to happen? Lung will repeatedly open and close, and this will cause a lot of shear trauma, which will lead to biotrauma. This will lead to injury. Okay, so we have to give some PEEP, and it depends how much PEEP you want to give. Guidelines suggest that if a patient is having severe form of ARDS, then you have to give high amount of PEEP. High means PEEP more than 10. If the patient is having mild to moderate form of ARDS, then PEEP of 5, 10, maybe 8 is good. Then comes the inspiratory time to total time. It depends upon the respiratory time constant. The respiratory time constant is a multiplication of resistance, as you can see here in the pointer, and complement. So what you will do in a patient who is adequately sedated and maybe paralyzed, you press this button. It will give you two readings. One will be resistance and one will be compliance. So let's assume the resistance is 20 and compliance is 20. So if you multiply them both, it will be 400. It will be 400 microseconds. So if you convert it into second, it will be 0.4 seconds. So what we have to do, we have to multiply this respiratory time constant with 3. If you multiply it with 3, there will be expiratory time. So you have to keep that much of the expiratory time. So let's assume the respiratory time constant was 0.4. You multiply it with 3, it will be 1.2. That means 1.2, at least 1.2 seconds of time you have to give for expiration, which means that you will be able, or patient will be able to expel 98% of the tidal volume in that time. Now, if you see these graphics, you see this is the inspiratory time and this is the expiratory time. We checked our ventilator on chest lung. This is a kind of bag which is having very low compliance. If you compare inspiratory time and expiratory time, it is not normal. Normal is 1 for inspiratory and 2 for expiratory. But here the expiratory time is really very less. That means that bag or that lung is having very low compliance. So this is how you set your inspiratory to expiratory time. Then is plateau pressure. T-plat, this is the time here you are giving when there is no net flow. It is 20% of the total inspiratory time. We give it because it's going to stretch the alveoli, inflate the alveoli over the period of 20% of the inspiratory time. It will increase the mean airway pressure and better oxygenation can be maintained. Here the trick is, say you are unlucky or the patient is unlucky, patient is having COPD with ARDS. Now you have to be very careful because if you increase this time, then there will be increase in the inspiratory time. And as you know, COPD patients are having really very bad resistance. Their resistance will be very high. So better you avoid this time, plateau time during inspiration. Then come the peak pressures. Peak pressure will tell you the pressure at the level of the YP. So the significance is if there is any sudden increase in the peak pressure, say it was 40 or 35, now it is suddenly 50. Then you have to see what is the reason. If there is any increase in the peak pressure without any increase in the plateau pressure, that means there is some kinking of the tube, some secretions are there, or there is some problem with the circuit. So you have to take care of it. If there is any increase in the peak pressure with some increase in the plateau pressure, then the diagnosis is that there is something, some obstruction to the HME filter or there is some pneumothorax. So by playing with these ventilatory settings, by seeing ventilatory graphics, you can help a patient. Okay. This is the minute ventilation. Now coming to the flow. This is the constant flow which we are routinely using, and as such, if you want to understand the patient ventilator asynchronous, better you use this mode because our eyes are usually trained for this flow pattern. This is the inspiratory trigger. The inspiratory trigger is the pressure with which when patient's body achieves a particular pressure, the ventilator will start helping the patient or assisting. So you can keep your inspiratory trigger around 2. Here it is 1.5. This trigger is pressure trigger or flow trigger. In present day ventilator, there is hardly any difference if you use pressure or volume. They are more or less same. This is flow, which I was talking about. Coming to the pressure support, again, this is now in the VCD that was kind of a rectangle. Here it is decelerating flow. This is characteristic of pressure support ventilation. Okay. Then again with FR2, you start with 100%. You can use directly pressure support ventilation in a patient who is having milder form of the disease, and you intubated the trachea because of something else, maybe because of coma, maybe because of requirement of high dose of vasopressor. So, as such, in a severe form, you should not use pressure support ventilation. Again, because if you're using pressure support ventilation, the patient has to be awake and patient should be able to trigger the ventilator. The negative pleural pressure may be there, and which will lead to increase in the transfer nerve pressure. So pressure support ventilation should be given when you are weaning a patient or when the ARDS is not that severe. In severe ARDS, you should not give pressure support ventilation per se. We keep pressure support which is above P, and the target of the pressure support is to deliver some tidal volume which is 6 to 8 ml per kg of the predicted body weight. We keep this is the minimum respiration, so it is the backup setting. If the respiration falls down below a particular range, maybe you have given some sedation, some paralysis, something happened wrong, then it is for the backup so that patient may not die because of hypoxia. Again, this is P. Coming to trigger. So in the pressure support ventilation, you can keep your trigger around 2. Here comes the role of expiratory trigger. What happens in these patients, in stiff lung patient? If you see here, the time during expiration is lower as compared to time taken during inspiration. So you will keep expiratory time towards the lower side. By default, the setting is fixed to 25, but in ARDS patient, in obese patient, any sort of patient who is having restrictive lung disease, you will keep it around 10 to 20, maybe 15. Okay, this is slope. The slope defines the time taken from point 0 to reach the peak inspiratory flow rate. So you have to keep this slope so that this should not be like this. It should be a perfect rectangle with the angle around 80 to 90 degrees. It is slope. In some ventilator, it is rise time. In some ventilator, it is T time. Okay. Now coming to the guideline, what we should do in a patient who is having hypoxia. If there is any hypoxia, we should understand whether the patient needs endotracheal intubation or not. If a patient needs endotracheal intubation, go ahead, intubate the trachea. But the person who is best trained in doing this should intubate the trachea. If a patient is not in need of any endotracheal intubation, then should be given supplemental oxygen. If a patient is not tolerating this supplement oxygen by face mask, you can consider high flow nasal cannula. Now there are many problems with high flow nasal cannula. First is you cannot attach viral filter in this. So there is a fear of aerosol development and aerosol formation. So there's a problem with it. Plus, you cannot give a peak of more than 5 to 7 practically. So that's also a concern. Therefore, we should consider it in a patient who is having relatively good chest condition. If a patient is in moderate to severe ARDS, we should never use it. Again, if a patient is tolerating it fine, no, you can consider non-invasive positive pressure ventilation by attaching face mask, or you can directly intubate. Now, this is the non-invasive ventilation through face mask. So there is a lot of controversy regarding it, whether we should use it or not. The problem is, that we can use it in certain set of population. The settings will be more or less what you set in pressure support mode. FI2 to target SPO2 around 88 to 94%, pressure support to target tidal volume of 6 to 8, peak again to improve oxygenation to 92 to 94%, expiratory trigger 2, expiratory trigger 10. Now the issue is, if you are giving lots of positive pressure by using non-invasive ventilation, it's going to cause gastric insufflation and patient may drown into his own secretions if he aspirates. So there's a trouble. And if you kept a patient in non-invasive ventilation, believe me, patient needs fair amount of monitoring. There should be some close monitoring if you are putting non-invasive ventilation. Now coming to the issues with non-invasive ventilation is the population. As we all know, the sicker the lot, the more the chances of COVID-induced problems are there. So what happens in older population? They are edentulous, some will be, and because of shagging these cheeks, it is very difficult to fit an IV mask. So there will be leak, and if there is any leak, the ventilator will trigger a lot. There will be increase in the tidal volume, and there will be increase in the chances of aerosol formation. Again, failure rate is high because the transpulmonary pressure may be very high in moderate to severe ARDS. So the bottom line is, if you are using non-invasive ventilation, you see the patient for 10, 30 minutes, maybe 2 hours. If a patient is not fine on non-invasive ventilation, intubate the trachea. That is more comfortable to the patient. It will cause more benefit to the patient. The other thing is this viral filter. Whenever you are using non-invasive ventilation or any kind of ventilation, even if you are using bag and mask ventilation during intubation, although it is not recommended in COVID patient, you must use this viral filter. It is lifesaver, especially for healthcare provider. Now the question is, okay, we need intubation, but when? Okay, when patient requires it. Who the most eligible person? Where is the answer is wherever the patient needs. If you can shift the patient to a cordoned area, it is very good. But if a patient is in emergency, patient is in cardiac arrest, immediately intubate, but intubate with all safety gears on. We should not risk our own lives. We have to be careful about it. And there is some query about this, that okay, we have intubated the patient, where we should keep now. In ICUs, in Western world, like it is quite logical that we should keep this sort of the patient in negative pressure room. But believe me, we don't have negative pressure rooms in AIIMS also, and we have to deal with it. So whenever it is available, well, it's very good. But if you don't have, keep the patient in normal pressure room. Now coming to how we should secure the airway. Avoid bag and mask because it's going to cause more aerosol formation, and secretions will be all over the room. So it's going to cause more damage. You should use rapid sequence induction. Give fair amount of muscle relaxant. A patient should not cough or burp at the time of the intubation. The other thing is you can use a plastic transparent sheet like in this picture. This is the video laryngoscope, which is as such recommended to intubate the trachea. If you have it, good. If you don't have it, use the normal laryngoscope. You make a small nick here, insert the blade of this, and insert your hand below the sheet. This is the endotracheal tube. Filter is on. You intubate the trachea and immediately attach. So by doing this, you can avoid the spray of aerosol and you can save yourself. Post intubation, put all your intubation equipment in a leak-proof bag and ask your technician to wipe them thoroughly with detergent and water. Then you can use 70% isopropyl alcohol to clean it. Scene safety. It is very important because if we are alive, we can save more patients. If we are dead, we are dead. So this is the circuit setup. This is the patient end. This is the closed suction. This is the filter. And this is tubing. Okay. Coming to the formal guidelines regarding management of acute respiratory distress syndrome. So these guidelines were laid down in 2019. In COVID guidelines, what they suggest that if the patient is having mild form of ARDS, you give around 4 to 8 ml per kg of the tidal volume to achieve a plateau pressure less than 30 centimeter of H2O. Sorry. Meanwhile, we should investigate for bacterial infection. Maybe patient is having community-acquired infection, or there are cases when patient develop influenza and COVID infection altogether. So we have to also investigate for swine flu or H1N1 infection. Target is to keep the saturation around 92 to 96%. We must consider conservative fluid therapy. Empirical antibiotic should be given if there is any doubt of bacterial contamination, bacterial infection. But antibiotics should not be given just for the sake that patient is on ventilator. That's not fine. Prophylactic antibiotic will not work, and we have to save our antibiotics because we'll not be having that much antibiotics in our hand. Plus, there will be multiple resistant organisms playing around with us. In patients with moderate to severe ARDS, consider high P. In many studies, it is shown that it is better to give higher P. It is associated with better oxidation. We can give neuromuscular blocking agents. We can give, say, atracurium, cis-atracurium to facilitate ventilation. Boluses are considered to be better than infusion in moderate to severe, but as a rescue therapy, you can start infusion also. We can give recruitment maneuver, but we have to be very careful at this point, because if the ARDS is well settled, it is more than 3 to 5 days, your recruitment maneuver will not act. Plus, what we do in recruitment maneuver, we give supra high positive pressure. And this supra high positive pressure is going to cause decrease in the preload. And there will be hypotension. So what you can do, if you want to give recruitment, you better rule out right ventricle dysfunction. You can do transthoracic echocardiography, and you can rule it out. Then only you should give recruitment maneuver, otherwise you may cause harm of some sort. If you are not able to maintain saturation, even after giving PEEP of 0.6, FI2 of 0.6, PEEP is high, then within few hours you have to decide about prone ventilation. But there is a problem here. You have to give it for 16 hours at least. The problem is, when you prone a patient, there will be lots of secretion pouring around. So those secretions are dangerous. They on their own can cause harm. So what you can do, you can keep cotton just beneath the head, so that that cotton may absorb the secretion, and then you can remove those secretions, discard them in some plastic bag which is leak-proof. Okay. As such, short cases of systemic corticosteroid, here in the guidelines it is written that you can give, but literature is not that strong. I'll be coming to it. For restrictive therapy, there is uncertain role of antivirals, chloroquine, but in severe form you can give it because we don't have many options available to us. Here, if we talk about nitric oxide, we can give a short trial. There is no role of high flow, high frequency jet ventilation. There is no role. We can consider ECMO if PO to FI2 ratio is less than 80. Despite playing around with the ventilator setting, we can consider ECMO. There is a lot of controversy regarding ECMO, especially a recent published trial. But if you don't have many things to do, you can do it. So coming to the PEEP, this is the high PEEP chart. It is taken from ARDS net trial. We can use it, especially in moderate to severe ARDS. Okay, coming to the corticosteroid. According to this published paper, people used steroids in MERS coronavirus, SARS coronavirus, and there was no proven benefit of using steroids. But the recent guidelines suggest that if a patient is having severe form of disease, you can give a trial of it, see whether the patient is improving or not. If a patient is not improving, you can stop it 3 to 5 days, within 3 to 5 days. Okay. Coming to the care of the patient, we have to do vital monitoring, which is SpO2, ECG, NIBP, urine output, sensorium, and invasive monitoring. This invasive monitoring means invasive arterial blood pressure. There is no role of CVP monitoring in these patients, especially if you are using very low tidal volume. It's not going to cause benefit. There is absolutely big no for CVP guided fluid therapy. That is dangerous in these patients. Better not to think about it. In the respiratory mechanics, we see peak airway pressure. We see plateau pressure. The plateau pressure should be below 30 mmHg. Driving pressure, which is a calculation in which plateau pressure is divided with P, it should be less than 17, maybe less than 15. Transforming pressures, if you have that equipment available, you can use it, but believe me, it is not available at many times. We do use it in some patients. For inspiration, we have to keep the transpulmonary pressure during the inspiratory phase less than 25, and during expiratory phase, it should be in between 0 to 2, 0 to 4. Some suggest we keep it around 2. You can do lung imaging. The problem here is that you cannot shift a patient of severe ARDS, even mild to moderate ARDS, to CT scan just to make some diagnosis. It is very risky. If your transport is wonderful, then you can do it, but believe me, it is very risky. So you should be aware of using ultrasound in these patients. There is also a controversial role of electrical impedance tomography. We are not using it, we don't have this machine. So our experience regarding this machine is nil. For the sedation, you can give fentanyl, morphine, propofol, whatsoever you like. For the relaxant, you can give boluses of cisatracurium or atracurium. This vecuronium is a steroid compound. Okay, it is associated with more chances of myopathy, so better you jump to cisatracurium or atracurium. And you should not use it for more than 48 hours. Coming to suctioning, this is very important. Look, when you are suctioning the trachea, patient is bound to cough. So prior to doing it, give sedation. Do it as and when required. There is no fun in doing on hourly basis. If you are doing hourly basis and if patient is not requiring, you are poking the trachea, patient is going to cough and secrete a lot of aerosols around. So it is not required. We should use cross suction only. This is very, very important. And the person who is taking care of the patient must use personal protection equipment while doing suction. So this is the cross suction which we use. We attach a syringe here, and this is the port where you can attach your suction tubing. Coming to the nebulization, we should avoid routine nebulization. There are many trials which suggest that's not going to help. Plus, to do nebulization, you have to disconnect the circuit, and this is very hazardous because there will be loss of feed and it's going to cause more trouble. So even if you want to give with MBI, not with the nebulization. Okay, that's not safe. And when you are doing it, what you can do, clamp the endotracheal tube with artery forceps. I will be explaining it in the demo part. Or umbilical cord clamp, quickly disconnect the circuit, attach nebulization kit, connect it, and do the nebulization. And when you want to disconnect the nebulization kit, repeat in reverse way. By putting a clamp or artery forceps, what's going to happen? There will not be any loss of P. But one has to be careful while doing this. You have to attach the circuit immediately. It should not be first you are putting the forceps, then you forget about how to connect the circuit. It is going to cause more harm. Here, the problem with bronchoscopy is that again, chances of contamination is very high. So bronchoscopy is done only and only when it is absolutely indicated. It should not be done just for the sake of getting secretions or getting samples. You can very well do it by endotracheal aspirate. One has to take care of complications like barotrauma, right ventricle failure, hemodynamic instability, and infection. So in the bleeding part, if the IE ratio is normalized, FID is less than 0.5, PEEP is less than 10, you can start bleeding. Okay, so if all the parameters are matched, you give a TP trial or CPAP, or you decrease the support by putting the patient to pressor support, then decrease the pressor support and decrease the PEEP. If the PEEP is less than 6 or maybe 8, you can give TP trial. If a patient tolerance TP trial, well, you can extubate. But the thing is, we should not extubate a COVID patient on NIV mask. We should always extubate the patient on face mask. Otherwise, it's going to cause, again, aerosol formation. That's our concern. For the extubation, there are certain guidelines like if you are planning for extubation, it should be done gently. Patient should not cough. When you are extubating, you should avoid tracheal suctioning, especially if the duration of illness is less than 2 weeks, because patient may spray virus around you. And if it is more than 2 weeks, you can treat the patient as non-COVID one. Discharge from the IC to isolation ward again depend upon the duration of the illness. Less than 2 weeks, you consider them as infected patient. As such, when you are extubating any COVID patient, you should use full personal protection equipment to save yourself. If it is more than 2 weeks, then the chances of infectivity is less. You may consider patient as non-COVID patient, but it depends upon your personal setting, how much personal protection gear you are having. If you are having plenty of them, treat each patient as still positive patient. There is a query about how to deal COVID patient who develop cardiac arrest. Say the patient is in the ward, patient was NIV, suddenly patient is in cardiac arrest, or patient is in cardiac arrest in the emergency room. The problem is CAB, you will secure circulation, then AV in the breathing. When you are compressing the chest and patient is gasping, believe me, patient will liberate lots of virus in the environment. So you have to secure the AV as soon as possible and use personal protection equipment to protect yourself from aerosol generating procedure. The other thing is, if the patient is on ventilator and develop cardiac arrest, our ventilators, what's the problem with the ventilator is they have some inspiratory trigger, and you cannot switch off that inspiratory trigger. So if you keep your patient on ventilator and you are compressing the chest around 100 to 120, maybe 130 times a minute, it is going to cause triggering of ventilator 120 times. So there will be no net movement of air in and out the lungs. Lungs will be super inflated. There will be decrease in the preload. The whole rationale of doing chest compression will go into dustbin. So put the patient. So put the patient to AMBU with some viral filter on during cardiac arrest. Do CPR. Try to avoid aerosol. Thank you. So we can demonstrate how to attach and deattach the circuit. The other thing is I can give you a brief idea about the ventilatory modes, how to play around with the ventilatory settings, and then we can have question answer round. So this is our circuit. Okay, now you see in this circuit there are water taps. So in any patient who is having high risk of contamination, ideally you should use the circuit which is not having the water traps, because with inspiration and expiration, lots of secretion will deposit here, and your technician has to be very careful. He may, or because of certain reasons, it may spill out. The other thing with these water traps is there are chances of leak in the circuit because of these water traps. So there's a problem with this kind of circuit. This kind of circuits are usually available with the ventilator. They comes with the ventilator. These are silicon circuits. The commercially available circuits are single tube circuits, or the circuit which is not having this kind of devices. You can use those circuits. Now this is our endotracheal tube. You see, this is our endotracheal tube. This is the subglottic supracuff suction. So what we will do, that you can use low pressure suction here. Low pressure means the suction around 20 centimeter of S2O pressure. So you can just attach a 2 cc syringe and ask your technician or nursing staff to do suctioning through it every hour. Okay, that's going to cause decrease in the chances of ventilator associated pneumonia. Just attach your syringe here. Every hour you have to do it, and then you have to throw it as super contagious thing. These secretions will be contaminated, they will cause harm. Better you use closed circuit low pressure suctioning system. But I know at many places it is not available. Now this is the cross suction system, which is recommended in any kind of infections, maybe even in Acinetobacter infections. In COVID, it is must. If you don't have this, you have to be very careful while doing suctioning. You should give some sedation to the patient so that it may not, patient may not cough and it may not spray. Okay, this is the viral filter. It must be on in every patient. If you are using your viral filter here, you can attach one filter in the expiratory limb. And if you attach your one filter in the expiratory limb, it's going to cause almost zero damage to your ventilatory circuit. And towards the end of the management, you can discard. There are many recommendations when to change this circuit. As such, if this is not contaminated, you can use the circuit as well as filter for 5 to 7 days. If there is some visible contamination, some secretion in the HME, you have to change it immediately. Otherwise, it can be used for 5 to 7 days. Okay, I was talking about how to disconnect the circuit and attach. Say, now you have intubated the trachea of the patient. This circuit is, this endotracheal tube is there in the trachea. Just after the intubation, you clamp it, ask your technician to put it like this and reopen it. By doing this, what you can do is you can avoid the spray or the secretions or the vapors coming out of this endotracheal tube to the environment. Same is when you are doing nebulization. You clamp it, put your nebulization unit here. It should be proximal to the HME. Put it again, clamp it, attach it, deattach the artery forceps. By doing this, what you can do, there will be no or minimum aerosol spraying, and also the loss of PEEP will not be there. In this patient, both of these things, like if you lose PEEP, it will take many hours, maybe 6, 7, 8 hours to recruit the lungs again. It is very difficult to recruit the lungs. Okay, this is one way of doing it. This is how to take care of this circuit. The other thing is ventilator. Okay. So now this, as you can see, is a volume controlled ventilation. So in the VCV, there are certain setting like FiO2. You can increase or decrease the FiO2. Okay, as per the requirement of the patient. Sorry, FiO2 is there. Sorry, FiO2 is there. So just after intubation of the trachea, you keep your FiO2 around 100, and then you decrease over the period of time. You maintain, you target your saturation around 92 to 96%. This is the flow trigger. You can use flow or pressure trigger, whatsoever you have in your ventilator. They both work fine in present day ventilators. This is the inspiratory pause. which I was talking about. So in around 1 second, then you can keep your pause as 10.1 second or 0.2 second. So by doing this, what you will do in a case of ARDS, you will inflate the lungs towards the end of the inspiration. It will help in generation of better mean pressure, better oxygenation. This is the peak flow. In few ventilators, you cannot play around with it, but in this ventilator, you can increase or decrease the flow. 60 liters per minute of flow is very good for this patient. Tidal volume, again, in the tidal volume, you keep the tidal volume as per the predicted body weight. Respiratory rate, usually 25 to 35 respiration per minute is required. In the some like advanced settings, okay, if you want to know about the this thing, plateau pressure, you will give the inspiratory hold over the period of 0.5 to 3 seconds. In some ventilator, 0.5 seconds will help, and in some ventilator, it is around 2 seconds. So by doing inspiratory hold, you'll get to know about the plateau pressure. Target is to keep the plateau pressure below 25. Expiratory hold is done to see the expiratory peak. Now coming to the this pressure support ventilation. Okay. In the pressure support ventilation, again we keep FiO2 flow trigger. You can keep it 2 or 3 liters per minute, depending upon the patient you have. Pressure support you give to target the tidal volume around 6 to 8 ml per kg. Okay, there is expiratory trigger which you can keep around 10 to 20%. So these are the settings when in pressure support ventilation. To treat COVID-19 or any form of ARDS patient, we must be aware of using VCV and PSV. There are many modes like APRV, BiPAP, bi-level. You can use lots of modes. But if you have basic understanding of these two modes, they are going to work. So now we are open for question and answering. With me is Dr. Saurabh. He is consultant in pulmonary medicine. And now we can answer the questions.
So, can you please unmute Galaxy Note 9?
Okay, there is a question regarding the role of APRV. The role of APRV is there. As such, if we talk about COVID, there is no data available about the role of APRV. As such, in other form of ARDS, viral pneumonia related ARDS, there is role of APRV. It will help in better oxygenation. But if you talk about the survival is more or less same. So again, it is not about the ventilator, it is about the person who is operating the ventilator. You can if you are comfortable with it, if you know how to use it, you can. In my experience, in few patients, it really works well. It helps in better.
So what is the exact personal protective equipment that you are using? Because here there are different versions of personal protective equipment, and we are not clear as to what is the proper PPE that is being used in India.
The question is about the use of personal protection equipment. So the use of personal protection equipment depends upon the zone you are working. Say you are dealing with these patients in the ICU, you have to wear a leak-proof gown, a plastic sheet beneath it, face mask, COVID, a face mask above it, eye cover,
Next is
head
Dr.
cover, a hood if it is available, 2 gloves, and foot cover. So you have to wear all these things. That's going to help.
If you are in screening area or if you are handling the OPDs where you have suspects, then wearing a face mask is fine and maintaining the distance of 1 meter with the patients is fine. If you are dealing with the stable patients in the screening area. But if you are dealing with ICU patients, then you have to on ventilator or in IV, then you have to wear the entire PPE including cap, hood, goggles, etc.
Thank you, sir.
There is a question from Dr. Vishwanath. Is it better to use pressure support with AIIMS as we are practicing as best method for winning? Sir, the problem with AIIMS is you are giving some mandatory ventilation over the period of, say your AIIMS setting is 10 mandatory ventilation. Then you are giving pressure support and patient is generating a total respiratory rate of 22. What is the problem with AIIMS? That over the period of 10 respiration, patient will breathe up to a certain inspiratory time which is set by the ventilator. For rest of the 12 breaths, which is initiated by the patient but supported by the pressure support, patient will breathe over the certain neural time. So there will be conflict in between the machine ventilatory time and the neural inspiratory time. And because of that, the asynchrony is practically more. We were using it around 10 years back. Now we are not using it. If there is asynchrony, what you will do, or what somebody, your resident or your junior will do, he'll pump a bolus dose of relaxant just to take care of the synchrony, and it's not a wonderful idea. So if you can try, just pressure support is going to help. You can play around the settings of pressure support, but better not to use AIIMS with pressure support because it's going to cause more asynchrony. Literature is also not in favor of it. There is a role of nebulization. Here the question is that if a patient is post-TB sequelae with fibrocavitative disease and you have to give nebulization. If you have to give, but you have to take all precautions, you have to clamp the circuit, you have to attach it immediately. Bottom line is there should not be loss of PEEP and spray of aerosol. If you can take care of these two things, you are well placed. And if you are not able to take care of these two things, it's going to cause more harm rather than doing good. We should not start nebulization just for the sake that we have to give it. If a patient is having spasm, yes, we have to give it. But we should not give it because we are giving it in every other patient.
You have to give nebulization on as needed basis rather than as a routine to everybody, even if you have COPD, asthma, associated post-TB sequelae. So you give it as needed rather than giving it to everybody who has endotracheal tubing. So you can use any bronchodilator, means you can use Estelin or means salbutamol, levosalbutamol as bronchodilator. Long-acting bronchodilators are probably not the best idea to use in acute stages, so you can use short-acting bronchodilators, ifratropiumab or salbutamol or levosalbutamol.
There is a question about.
Sir, please take a question of Dr. Navdeep Goyal.
Yes, the question of Dr. Navdeep Goyal is.
My question is, normally we're using a respiratory rate of 15 to 20, but you advise the respiratory rate of 25 to 30. Isn't that a high one?
Okay, Dr. Navdeep, the problem with ARDS is that you are not giving tidal volume, high tidal volume. So in my form of ARDS, basically it depends upon the compliance of the lung. If the compliance of the lung is good, you can give your tidal volume around 8 ml per kg. And the target is to match the PaCO2 and pH. So what happens in the severe form of ARDS, the lungs are very stiff, the working part of the lung is very small. So you at times end up with giving tidal volume of 4 ml per kg. Say the weight is 60 and you are giving 4 ml per kg, the tidal volume will be, the desired tidal volume is 240 ml. So to achieve a desired pH and PaCO2, you have to increase the respiratory rate so that you can achieve desired mid ventilation. So it depends upon condition to condition. If a patient's compliance is good, 15 respiratory rate will help. But if the compliance is bad, you will drop down on the part of tidal volume and you will increase the respiratory rate to achieve mid ventilation.
Thank you, sir.
Next question, Dr. Aurobindo Behra.
Yes, Dr. Behra.
Sir, ideally, good morning, sir.
Yes, good morning.
Sir, ideally, how many staff members should be present in a COVID-19 ICU? Because it is highly transmissible.
Okay, the question is very good, Dr. Behra. The question was how many staff should be there in a COVID ICU patient. Actually, it depends upon how many beds do you have. So, if a patient is like a nursing staff can take care of 1 to 2 patients depending upon how severe your patient is. Your resident or the doctor who is there can take 4 to 8 patients. One doctor can take 4 to 8 patients depending upon how severe the patient is. So if you are having 8-bedded ICU, you need to have at least 4 to 8 nursing staff, 1 to 2 doctors, then you need to have 1 technician and support staff you need. The duty hours should be relatively smaller because it is very difficult to work with full PPE on. You cannot work for more than 4 to 6 hours. Okay, so you have to arrange your staff according to that.
So there are a couple of questions on chat.
Yes. So there is a question. What are ventilatory settings for a patient with lungs in different stage of fibrosis, e.g. in full fibrosis and others in 50% fibrosis? So the problem here is just by seeing the patient, you cannot know what is the level of fibrosis. You can interpret respiratory mechanics in the term of compliance, in the term of elastance, in the terms of certain pressures like transpulmonary pressure, plateau pressure. So if the fibrosis is more, what we think is that compliance will drop down. So the plateau pressure will be high for one particular tidal volume. Say you are giving tidal volume of 400. In a healthy lung, plateau pressure may be 20, but in a sick form of lungs where fibrosis is more, it may be 35. So the ventilatory setting depends upon the compliance and the plateau pressure. You have to target the plateau pressure less than 30, and it will work. And fibrosis is a thing which you cannot see with your eyes in clinical setting, and you cannot shift a patient to CT scan frequently. So better you use your ventilatory screen, you interpret your ventilatory parameters, plateau pressure, driving pressure, transpulmonary pressure, and make a conclusion how stiff or how bad the lungs are, and accordingly you titrate your tidal volume or your respiratory rate. There is a question from position 8 is advisable then. The answer, Dr. Hina, is if a patient is in requirement of very high FiO2, say if the FiO2 is more than 0.6, PEEP is high, more than 10, 12, 15, and you are not able to achieve the saturation, the desired saturation of 92 to 96%, then you have to take the decision. In a patient who is not having COVID, you prone the patient within few hours, 6 to 8 hours, depending upon the expertise you have. In COVID patient, if you prone, there will be a lot of the secretions rolling out of the mouth, which is a potential source of infection. That's the problem. So what you can do is, you can keep a lot of cotton, allow that secretions to roll off, and then you treat that cotton full of secretions as highly contagious item, you discard it. As such, prone position is helpful in certain form of ARDS if the PO to FiO2 ratio is less than 150. Even after playing your ventilatory settings, even if your FiO2 is more than 0.6, 0.6 or 0.7, then you should prone the patient.
So portable X-ray means sleeve. So once you have a patient of ARDS, it takes time to go into the fibrosis. It's not that first the patient goes into fibrosis. Patients may have baseline lung disease, which we may know, which we may not know. But you can see X-ray, but X-ray will not show you fibrosis. X-ray will show you the haziness, which may be the ARDS, which is evolving, or it may be the end-stage fibrosis. So how it goes on an X-ray on a serial basis, then only you can say that it's a fibrotic stage of ARDS versus ARDS, which can still resolve. So getting an X-ray is fine to look at the lung status, but to consider that it's all fibrotic in the early stages of your disease, it's not right. So you have to look at the lung physiology rather than looking at the X-ray. So you are looking at your plateau pressure, your PCO2, respiratory rate is more important than looking at the X-ray and then deciding if the lung is fibrotic. I'm not going to do anything.
There is a question how to sterilize flow meter. To sterilize flow meter is first you wash them with detergent and water, then you can dip the flow meter in 1% hypochlorite solution, and that's going to sterilize it. The other question is, normal HME filter is same as viral filter. The answer is yes, it will take care of 99.999% of viral load.
How do we manage bronchospasm? So obviously, so bronchospasm, the treatment remains nebulization. If your patients have a baseline lung disease, which may be COPD or a bronchial asthma or a post-TB sequelae, then they are likely to have an obstructive physiology. So you may need to give them more nebulization, but it is on needed basis. Patients have spasm, your peak pressures are going on, your airway resistance is high, then you give nebulization. Agents, as we have previously discussed, nebulization is not preferred, but if it is required, it has to be given. It is not that patient who is requiring nebulization, you should not use it. You should use it judiciously so that not everybody is receiving nebulization. Second was steroids. Steroids, if you have bronchospasm, a patient who has asthma, now has come with a COVID disease with exacerbation, then you have to use steroids for treating their asthma, exacerbation, or simply for COPD, not routinely for patients who have a normal lung and now have come with mild disease.
There is a question regarding use of non-invasive ventilation and high flow nasal cannula. Regarding aerosol, there was a few days back, there was a report from the Hindu, and what that data suggested that amount of ventilator we have in India is limited. It is approximately 9,000. So if we are able to procure some more, it will be maybe 15,000, not more than that. So given that circumstance, if COVID is hitting us more than that, then we have to keep the patient on non-invasive ventilation. Yes, that is true that milder form of disease is more common in COVID, so you can use non-invasive ventilation. But the issue is you should be vigilant. You should not push your patient on non-invasive ventilation when patient is not maintaining saturation. Say, if a patient is not able to speak even one single sentence after removing of non-invasive ventilation, that means you should put the tube inside the trachea immediately. If you are pushing the patient too far on non-invasive ventilation, it's going to cause more harm. There will be more ventilator this non-invasive ventilation-induced lung injury, and the mortality is higher in that subset. So you can use non-invasive ventilation, but you should be very much cautious when you are using it. You should be, like all intubation facilities should be available, and you should not stress the patient. There's a question, can COVID patient be intubated in an emergency along with other patients or a separate COVID emergency area and team required? Answer is that COVID patient should be dealt at a separate area. If you intubate, like there are certain procedures where the aerosol transmission is more, like intubation, extubation, doing bronchoscopy, doing CPR. So when you are doing all these things, you should not mix COVID with non-COVID. The COVID emergencies should be different as compared to non-COVID emergency. If you are dealing with both subset of the patient, make a big curtain which start from floor to roof, separate those two areas. Don't mix these patients, and when you are intubating a COVID patient, make sure you all wear protective equipment. Or you can do small bits like you give full dose of relaxant, don't do bag and mask, do rapid sequence intubation. The most senior person should put it. Or you can use video laryngoscope. The benefit of video laryngoscope is that the chances of first pass success rate is more, provided you are well versed with video laryngoscope. And also, you can make a distance when you are using video laryngoscope. So you can use small bits to avoid aerosol transmission.
Use of steroids in subset of patients with hyperinflammatory state. So obviously, so Steroids are not routinely required. Subset means those who are severe ARDS, where steroids trial can be given, or for moderate to severe ARDS, we can.
Sir, what kind of air circulation should be there in a COVID ICU? Should it be air conditioned, or should the COVID ICU be air conditioned? What kind of air circulation be there in a COVID ICU? Uh, should fans be there, or should the windows be opened? Kindly explain. So I wanted to know the kind of air circulation that should be there in the COVID ICU. Should it be a air conditioned ICU with a air handling single air handling unit, or should fans be there, or
No. Ideally, it should be negative pressure system. But negative pressure system is not there, so you can use normal pressure system. You can use AC, and if you use fan, what is going to happen? The laminar flow will change into turbulent flow, and it will cause more dispersal of the virus. So if you are using fans, it is not recommended in ICU. You should not use it. You can better you avoid it. Regarding like in Italy, what they have done, they have converted OTs into ICUs. So if you are converting your OT into ICU, the problem is in OTs there is positive pressure, and if you keep your infected patient there, it is going to cause dispersal of the virus load outside. So that is the trouble. For that, what you have to do is you have to shut down the positive pressure, and you have to uh, the air filtration rate should be 10 to 12 times per hour.
thank you, sir.
Thank you.
Sir,
Yes,
Dr. Navdeep Goel has a question. So,
Dr. Pradeep, please.
Sir, I wanted to ask, the normal surgical masks that we wear, are they protection enough for COVID-19, or we have to use FFP3 masks?
This will not protect you if you are working in high risk zone. If you are working in the screening area, if you are working in ICU or emergency, you should use N95 mask. And if you are working like emergency or ICU, where you are taking care of sickest of the lot, you are doing intubation and all, you should use all personal protection equipment. This normal surgical mask will not protect you from COVID. If you are working with high risk zone, you should not use it.
But you can
In the
use it
ICU?
and if you are able to maintain a distance. If you are having in close contact with patient, you should wear N95. But you can, if you are between an outdoor or a screening area, where you can maintain a patient with a patient more than a meter distance, then you can use the triple layer surgical.
Thank you.
The question is from Galaxy J7 Pro. Any prophylactic medicines recommended for staff handling COVID patients? What is the report?
So now ICMR has come up with guidelines which have suggested use of hydroxychloroquine for healthcare workers who are handling COVID patients. So for now, it is hydroxychloroquine on day 1 and then weekly doses. So it is a recommendation from ICMR, but the availability of drug is a problem right now because probably we had less drug and once we release the guidelines. But probably it is too early to say that how effective it will be. But it is still, the answer is still questionable that how can we go about it. Some of us are using it, some of us are not using it. So we cannot make a definite answer to this question. But yes, ICMR and the National Task Force have recommended the use of hydroxychloroquine.
There is a question from Dr. Karandi. The question is, in situation of non-availability of ventilator, no option of referral to higher center, can we intubate the patient and use pipette with expiratory valve? Yes, you can use it. You can use expiratory valve. You must use HME filter. And actually, this pipette machine is kind of transport ventilator. It is not having advanced features like you have in advanced ventilators. But when we don't have option, we don't have options. So you can use it.
But the only thing is that you have to wear the entire personal protective equipment because it will be more aerosol generating if you are using NIV with NIV machine, and also and you'll have a problem with the setting also, because monitoring, if you have a ventilator sitting here, you can look at from distance. If you have a machine, then you have a problem with the monitoring also. So that should be more strong if you are using an NIV machine for a ventilator.
Again, there is a question, can we use one ventilator to ventilate multiple patients? Answer is we don't know. What I think is that ventilating graphics will not be available and you will not be able to interpret, as at this time we have not used it and we are not we cannot comment about it. There is a question from Sri. What about intubating children in which complete RSI might be difficult? Do you advise using LMA if all we need to manually ventilate during the process of intubation? Yes, if you think that if in a difficult situation you can use laryngeal mask airway, the aerosol formation is relatively less and you can go ahead with intubation later on. But the thing is, whosoever is intubating, that person should be the most eligible person around, and you should be able to take care of the airway in the shortest possible time with minimal ventilation.
So have you seen any secondary bacterial infection while treating the COVID patients? So obviously these patients are at high risk of secondary infection. If you have a mild disease, mild ARDS, then you may not give them prophylactic antibiotics. But for patients who are moderate to severe, are usually requiring antibiotics, even if we don't have any things to suggest severe bacterial infection. But it is preferable to use prophylactic antibiotics for moderate to severe rather than for mild disease.
Sir, there were a few reports in the media in which they have used one ventilator for up to 4 patients in the US, and they have used the pressure support mode or pressure control mode.
So the answer is there is no difference if you are using PCV and DCV. The problem is, if you attach one ventilator to 4 patients, what my understanding is, because I am interested in viewing the patient-ventilator interaction, seeing the flow over the period of time, volume over the period of time, or pressure over the period of time. So you will not be able to interpret those fine details, and it is going to cause trouble. As such, we don't have any experience, first-hand experience in interpreting in the use of these patients. This kind of ventilator they are not used. There is a question from Dr. Sri. Any preference in between LMA and iGel? Actually, if you want to discuss about the evidences, there are no evidences whether we should use LMA or iGel. If we speak logic, then the logic is that you should be able to secure the airway by using laryngeal mask airway or iGel, and there should be minimal leak so that the chances of aerosol generation is minimal. So you can use either of these two equipments, but chances of with which you can avoid chances of aerosol formation.
Sir, please take a chat question. Yeah.
Yes. There is a question. What is
the prophylaxis regimen for renal failure patients? So prophylaxis is not for patients at all. Prophylaxis is only for healthcare workers like us who are exposed with the COVID positive patients who are likely to get exposed. So right now, everybody is in panic mode that should we take hydroxychloroquine. So it is still recommended for healthcare workers who are likely to be in contact with the patients with COVID rather than for everybody.
Believe me, in Delhi and NCR, there is no availability of HCQ because lots of people in public are buying it, they are consuming it. And the problem with this kind of information is that when healthcare needs it, it will not be available.
What is the ideal PPE for collection of throat swab? So the ideal PPE is for collection of throat swabs that includes from head to toe, that you should have shoe covers, you should have gloves, you should have masks, You should have an impermeable gown, mask, which should be a N95 mask, and eye goggles or a face shield along with a hood. That is minimum. That should be there, which covers your neck also. So that is required for central connection.
There is a question from Dr. Devyani Thakur. The question is, in case of need for urgent intubation before shifting the patient to a high dependency unit or ICU, should we avoid umbo or vein circuit even in transit? The answer is, it depends upon your situation. Like if you are able to secure the airway and you have availability of transport ventilator, you can use transport ventilator. But in circumstances where you don't have transport ventilator, then you have to use umbo. You can use this ambo unit, but there should be viral filter. Without viral filter, you should not use it. And you should not use any sort of ventilatory device without viral filters. If viral filter is on, you can use ambo bag.
What is the role of proning in management of COVID? So the standard recommendation for management of ARDS remains there. The proning for patients who are not improving after 6 to 8 hours. Low tidal volume mechanical ventilation requiring very high FiO2, FPR to PFR ratio less than 150 or 100. So this should be prone. But the precautions which Dr. Rahul initially told, that you have to be very cautious if you are proning COVID-19 patients, because aerosol generation and secretions which drool out of mouth if the patient is in poor position should be dealt with safety.
The question is from Dr. Shakti. Will Sidex for 20 minutes be enough to sterilizing some non-contaminated instrument? Yes, it will work.
So right now we have some of the data which has shown that regarding proning, that even patients who are on NIV may be asked to lie down in prone position so that their ventilation can be better. So there is retrospective data on use of proning with non-invasive ventilation in patients with COVID disease.
The question is from Dr. Kishore. How to sterilize ventilator after using in COVID-19? If you are using the HME filter at the junction of tube and the circuit, and you are using expiratory valve, expiratory filter, then there is no need to sterilize ventilator. What you will do, you will discard the circuit. Once your patient is out of ICU, you will discard it, and then for surface cleaning of your ventilator, you will use Bacillol. The contact time should be around 5 to 10 minutes, minimum 5 minutes, and it will take care of that. You must use HME filter in between the endotracheal tube and circuit. Expiratory valve you should also use. For expiratory valve, what you can do is you can wash it thoroughly and can dip it in hypochlorite solution for around 10 to 20 minutes, and that will work. There is a concern about intubation, where we should intubate. The reasoning is quite simple. If a patient is in cardiac arrest, you have to intubate there and there only. What we can do at this time, because we have still 1 or 2 weeks in our hand, we can split the emergency into COVID and non-COVID. Any patient who is presenting respiratory symptoms, because respiratory symptoms are more common in COVID patient, they should be treated, or we should take care of them in separate area as compared to a patient who is coming with simply maybe because of heart failure, maybe because of MI, stroke. So we should not mix and match those two subgroups. If a patient needs mechanical ventilation, we need to intubate there and there only. We cannot shift to a pre-designated area because of, like, if the transport time is 2 minutes, it is good enough to kill the patient.
Then we have a question: what is your stand on availability of PPE all over India? Are we not risking our lives too much? So obviously it's a problem. It is on the administration part and availability part. Both are there. So number one is, whatever available PPE is in your hospital, it should be channelized well. Means it should not be used for places or work which is not urgent, non-essential, it should be channelized towards the COVID patients if you have that area. Obviously, this is a problem that availability of all PPE may not be there in all places. And in that case, probably whatever we have, we may have to work with that. So obviously, we are kind of risking a little bit. But if you have, that's why it is important that you should know when to use all the PPEs, when to use the 3-layer mask, when to use the N95, to judiciously use it. If you use the entire PPE for each and everything, once you are involved, once you are in ICU, once you are in emergency or screening OPD, then it will be a problem. But if you have a correct understanding that when should I wear what, you may be able to handle the situation in a better way.
There is a question from empirical antibiotic for severe ARDS should target MRC. It depends. Like in viral pneumonia, it has been seen that supra-added infection or that may be gram-positive infection. In that subset of the patient, you can use it. But if the ARDS is because of something else, then routine you should not routinely give MRSA coverage. It is like wasting the drugs. It depends upon condition to condition. The other question is, for patients presenting in respiratory distress with unknown COVID status, how to approach regarding where to intubate, separate team required, and transportation. Again, where to intubate, it depends the severity of the illness. If patient needs emergent intubation, you will intubate there and there only. Yes, separate team requirement is there because chances of aerosol transmission is there. You cannot expose all healthcare workers to COVID. Regarding transportation, you secure the airway first. Then you can transport depending upon the facilities you have. You can transport with the help of transport ventilator, with the help of ambu bag. But bottom line is there should be viral filter in between the tube and the circuit.
So patients who come with respiratory failure with a known COVID or COVID suspects, if you have some history, if you are not able to reach a diagnosis with the initial history examination, then what is the likely cause of this patient's respiratory failure? So they are COVID suspects and should be dealt like that.
The question is from Oppo F9. How to sterilize dragger ventilator if we are not using HME filter in emergency OT scenario? The question, the answer is like, okay, I presume you are talking about OT setting. So if the question is, if you are taking care of COVID patient and unknowingly, knowingly you have taken the patient to emergency OT without use of HME filter, then how to sterilize dragger ventilator? First is you have to discard all the tubings. Your ventilator or the OT ventilator, you can remove the circuit and then you can start treating it. You can dip it in hypochlorite solution or Sidex, or you can even use autoclave to sterilize it. But better at this time, if history of contact is there, respiratory symptoms are there, if the history of foreign travel is there, consider this sort of patient as COVID patient. That's going to save your manpower as well as save your resources.
So what is the criteria for repeat testing in a COVID positive patient? That once you have positive report, after 2 weeks, 14 days, you have to take.
No idea यार अभी मतलब.
You have to take 2 samples, and both of them should be negative to call it a COVID negative patient now. So that means you take 2 samples which are 24 hours apart after 2 weeks of a positive sample.
There is a question from Lenovo. In case of long transit time to an ICU, are we justified of using nebulization and steroid to relieve respiratory distress?
So you can use steroids, but nebulization, the same thing remains, that you can use nebulization, but you should be able to protect yourself. You are going to create more aerosol if you are using nebulization. So if you can have an area which is separated from, even if you are not in ICU in a separate area and you are able to sterilize it later on, that means you can use nebulization. It all depends upon your patient's condition and how emergent it is. If you think it can wait for 10 minutes, 1 hour, 30 minutes, if it can wait, it can wait. If you think it is emergent, then you have to use it.
The other thing is, like, you want to give nebulization just for the transit time. Nebulization will work if there is some spasm. If spasm is not there, what do you want to treat? So just to buy some time, there is no fun in starting it. If there is any issue, regarding like if there is some spasm, then you can give. If there is no spasm, better avoid it. And for transit time, you can use an IV mask. There are certain NIV masks which can directly connect to the flow meter. There is some valve which can give a peak of 5 to 10. So you can that sort of things rather than just nebulizing because you want to stress sometimes.
So next question is from IMSR Mulana.
Yes, yes.
मतलब वो ट्रांसलेट कैसे करेगा मेरे को समझ नहीं आ
Yes, please.
Yes, IMSR Mulana. Please ask your question.
रहा प्राइवेट
We'll move to the next one. 1 plus 3.
1 plus 3, please.
Please ask your question.
Meantime, we'll take a question from chat. There is a question: monitoring of patient progress. Any markers? I don't think there is any marker to suggest the patient's progress. It is you will do. You'll see like in a patient who is having pneumonia or ARDS, you have to, and patient is in ICU. You have to see the respiratory mechanics and the radiograph ABG. These will tell regarding the clinical condition of the patient, whether the patient is improving or not. As such, there is no marker available which can tell, okay, COVID is improving or not.
So how can an asymptomatic patient transmit when he does not have secretions? So secretions is everywhere. If we are speaking, we are still generating some degree of droplets which are going around. If we sneeze, if we have a little bit of cough, just one cough, or we speak loudly, we generate droplets. So it is not possible. It is possible that somebody who is asymptomatic, just talking, can lead to secretions and droplet formation.
And like in the first week of the illness, when patient is relatively asymptomatic, chances of transmission is more. Once the patient is in the second week of the disease, the chances of transmission of the disease is relatively less.
Okay, question is that can it be the test results are negative because of error in proper sampling? What could be the solution to this? So obviously, so whenever you have some resident doctor, technician, or a nursing officer who is taking the sample, it is important the correct training should be done at how to take the sample, because obviously the test is costing to government, and if you use the test which is, if sample collection is not right, then you'll have a wrong report. But probably this is not the primary problem in most of the cases, because it is not a very big thing to take a sample, or not a very hi-fi technique. It's just that correct way the sample swab has to be inserted and rotated, and then sample should be collected. So it is probably not the reason that sample are negative, which is a concern for many people, that probably AIIMS has had a lot of negatives. So they are saying that whether sample collection is right or not. The sample collection is happening. This is done by the resident doctors or the technicians, which have been taking these samples for other viruses also. So that's not a problem.
There is a question from Esser. Can two COVID-19 patients in different stages of recovery, one on only oxygen and the other who is sick on mechanical ventilation support, be placed together? The answer is, like, I presume the setting in which you are working is having limited amount of resources, as we all do. We are not having, so the you can say the amount of bed or the number of beds in ICU are limited. So if you place one sick patient and one fine patient together, it is like wasting of the resources. So better you shift a patient who is just on the oxygen to some isolation ward, and the patient who is on mechanical ventilation in ICU. You cannot waste your bed because we have limited resources to keep one patient who is relatively fine in ICU. That is not desirable.
So question is, any other signs
I
or symptoms
just
of
wanted to
COVID
make an
hitting
announcement.
other system other than the lung? So there has been reports of cardiac arrhythmias, which may be related to whether myocarditis or related to viral illness. So it is like any other virus which can lead to other manifestations of the viral illness, which may include multi-organ failure or cardiac dysfunction, but it is not widely reported. The primary problem is the respiratory failure and ARDS.
Sir, I just wanted to make an announcement. We'll be sharing a feedback link with the feedback form on the chat, and I would request everyone to fill it up because that will help us improve in the future sessions. So I would request everyone to fill up the feedback form with the link given below. Palash, can you please share the link? Thank you.
There is a question from Dr. Shakti. So no AC, no fan either, the dogs or the patient will suffer from heat-related illness. I don't know how to answer this question or how to address this question. But right now in Delhi, the temperature is nice. It is 26 to 28 degrees Celsius. And for coming 15 days, we are not going to die because of heat stroke. Let's hope for the best.
So you can kind of, for healthcare workers at least, what you can do is that you can reduce the duration of their shift. So what we are trying is 4-hour shift. So 4 hours is an acceptable time for somebody who can stay in the PPE without eating or drinking or going to washroom. So those shift durations may be reduced depending upon the manpower you have.
There is a question, role of acetylprophylline or azithromycin.
So azithromycin has been used, but you see there is no definite answer to this question that whether azithromycin leads to earlier resolution of the illness. So we don't know the answer. No role of acetylprophylline. So these drugs can be used for associated illness. If you have a patient who has COPD with exacerbation and he had history, he turned out to be COVID positive, then you can use these drugs and adjunct to your primary illness treatment rather than for treating COVID.
There is a question about use of anti-inflammatory and mucolytics. The role of anti-inflammatory is controversial. It is said that it is going to increase in the viral load. And regarding mucolytics, there is no evidence which suggests that if you use mucolytic, is going to help the patient. The thing is, like in viral pneumonia, the amount of the secretion is not that much initially. But if it is because of like superimposed hospital-acquired infection is there, then chances of increasing the secretion may be there. If you maintain adequate humidification, there is no need to give mucolytics. Okay. Then the question is, can we use pediatric ventilator like Nalcor for patient ventilator for adult patient in time of crisis? It depends. You go through the brochure of the ventilator. If the setting can be changed, actually in these ventilators there are two settings: neonate setting or pediatric setting and adult setting. If you can change the setting, and if the ventilator can give tidal volume more than 200, maybe 300, then you can use it for adult purpose.
Is there any incidence of COVID-19 spread through the conjunctiva? Since everybody is mentioning not to touch our eyes, I don't know the answer to this question, but probably what is best is that everything is in very close context. Whatever it is, an inhalational droplet infection only. So if you keep touching around, it is likely that infection is going to through your respiratory tract.
The question is from Dr. Indu. She is asking, can we stabilize patient in cardiac arrest with laryngeal mask airway in emergency room before shifting to IC for proper ventilation? Yes, you can do it. Like you can secure the airway. Bag and mask is not desirable. Endotracheal tube is the best because of decrease in the aerosol formation and spraying of the secretion. So LMA lies in between these two things. If the leak is not there, then you can put laryngeal mask airway and you can shift the patient to ICU. Okay. The other thing which you can do is you can, like here, you are putting LMA and then ventilating the patient. You can also intubate the trachea and ventilate the patient in the same way. So better is endotracheal intubation. Say patient is a case of difficult intubation or the staff is not there or somebody else is doing the airway management who is not that trained, then okay, you can put LMA, but better you go for endotracheal intubation.
So some articles, question from Pixel, that some articles say that using ACE inhibitor or ARBs in hypertension, use of thiazolidine in diabetes or ibuprofen increases viral replication. So how to justify that? So first is about the hypertension. There has been a big controversy about the use. Majority of the hypertension societies have said that you can continue to use ACE inhibitors or ARBs even if you have patients with COVID disease, or the susceptibility to COVID disease is probably not increased by use of continuing the use of ACE inhibitors or ARBs. Regarding the ibuprofen, it should not be used because anti-inflammatories can increase viral replication, that has been shown. Regarding the thiazolidine sign, I don't know.
There is a question from 1 plus 3T. In
Sir, he
scale
can ask audially. One,
yes,
if
yes.
you want to ask. 1 plus, can you please ask your question?
Yes, sir. Can you hear me?
Yes, sir.
You are audible.
Actually, I have put a question also there in the chat also. In scarcity of N95 masks, we are using anesthesia mask with a band and HMEF put on it. What is your stand on it?
I don't have any idea about it. If you talk about the guidelines, it is not recommended.
If you, sir, if you can take me on video call so that I can show you the basic concept.
Okay. Okay. Now you are on video call. Please.
Actually, this is the mask. This is the transparent mask.
We are not able to see you.
This is the
Yes, yes, yes.
mask.
Okay.
And we have put a HMEF over it.
Okay.
Since it is, if you talk about this N95 or triple layer mask, this is much better than what we see in those filters.
Yes, the design you are using seems to be good. The question is, sir, I have not used it, and what is your opinion for how many hours you can use it comfortably?
It is a reusable thing, sir. It is a reusable thing, and it is costing just 300 rupees.
Okay, so you can use it. The question is, for how many hours you can use it comfortably? Can you use it for 4 to 6 hours comfortably?
What all we thought is, since it is if it shows some contamination, we remove the HMEF and we replace the HMEF.
Okay. Okay. What concern?
There is a we can see that it is negative pressure we can generate. If I put this, let me show you one thing.
Okay.
Let me show you how I put it.
Please.
See, this is how we have tied the bands.
Okay.
This is how we have tied the bands, and I take all this like this. And I put it like this.
Okay.
And if I put my hand like this,
It seems to be a very good idea, Dr. Yashmi. And
Negative.
for sure, I will try to wear it. I'll try to use it.
Yeah, you please try to wear it because there is a scarcity of N95. I am an intensivist anesthesiologist at Hisar, Haryana, and I am secretary ISA Haryana also. So we have thought to do it for our patients, for our not for our patients, not for our people who are in close contact with COVID-19 patients.
The only concern I would have is that it will increase the resistance to breathing. It will become difficult to breathe with the HME attached to your.
It is not at all difficult. You just try it once. It is not at all difficult.
Okay. Okay. We'll try to use it. Thank you, sir. It's a good design.
Thank you, sir.
So please take a chat questions.
So we have a question from Redmi. WHO says droplet transmission and CGD says aerosol. Can you clarify about it and what should we follow? So obviously, so till now the transmission by WHO and the initial studies have shown that it is only the droplet transmission. Right now, in last week, NEGM also has shown paper that the virus can survive in air also. So till now, the WHO has not changed its stand, and we are not sure that how much is the role of aerosol in transmitting the infection. So till now, we believe that it is droplet transmission, but till we have more data that aerosol is an important contribution for transmission, that we cannot comment upon right now. but the droplet transmission is obviously definitely, but how much is the contribution of aerosolization over the droplet transmission?
There is a question from Motorola Bonpar. Any comments on concomitant drugs for the ventilated patients? LPV RT versus HCQ plus ositromer versus LPV with RT. The answer is that you should not use LPV RT with HCQ. It's going to cause increase in the concentration of HCQ, which may cause toxicity. Regarding ositromer, it is not recommended for the use in COVID infections. Regarding LPV RT versus HCQ, what do you think? Is there any head-to-head trial about it?
There is no head-to, but there is a trial which is ongoing regarding this. But for now, we have the recommendation of HCQ for severe disease, which may be tried. So that's all we can say for now. The use of combination antiviral is not yet recommended.
The question is from Dr. Suresh Prabhu. How long a COVID-19 patient is infected to others?
So since a patient who acquires infection from the time till at least 14 days, so we have to, so that's why the quarantine period has become 14 days. In 14 days, it is likely that there is no further transmission of the patient. So once you have a positive report, whatever time of illness it may be, you have to wait for 14 days from that time and take a repeat sample and to see that it is negative, then only you can say the patient is non-infected. So
there is a question regarding any special recommendations for HIV patients with COVID. In the recommendation and the literature we read, there is no such special recommendations for HIV patients. Yes, HIV patients are at the risk of more opportunistic infection. So we have to manage these patients as per standard guidelines. The other question is use of convalescent serum for COVID-19 patient to treat sick patient. Answer is there is no evidence which suggests that if you use this serum, it will help sick patient. So right now at this time, there is no recommendation to use it, better avoid it. Because it may lead to some other bloodborne infections also. You can ask any question if you want.
So we can take questions from the chat if you missed earlier. So
Suppose in a situation when we have 5 suspected COVID patients, we have only one ventilator. So how do we try such patients who are?
So the question is that if you have 5 patients who are in need of mechanical ventilator and you have only one ventilator, then what to do? The answer is it depends. Like then you have to go into triage. As such, if the age is more than 60, the mortality is around 6%. And in the patient population more than 80, the mortality is really very high, around 13 to 14%. So what is done in Italy is if the patient is more than 80 years, they are not providing mechanical ventilation because of the high mortality. So they are going with triage. In a young patient who is not having any comorbid illness, just respiratory illness, the survival rate is really very good. So in that circumstance, if we don't have resources, I'll go for a young patient which I can salvage. But for rest of the patient, you have to think that what else you can do. Like we can then start mobilizing our anesthesia machines. There is a ventilator there. So we should start mobilizing other resources also. If you don't have any resources, better go for trials.
So we have a question from Dr. Lal. In the case of a patient who has sore throat, no history of contact, travel, no respiratory distress, wherein do we ask this patient to go for testing? So as per the current recommendations from ICMR, this patient does not require testing for COVID-19. So that is very important because right now we have the ICMR has accredited some of the labs where people believe that they can go and get themselves tested. It's not like that. They still require a doctor's prescription in the form. So universal testing is still not there. So somebody who has a sore throat without any risk factors should not be tested for COVID-19.
There is a question from 1+6. Any specific guidelines for nutrition and fluid therapy in ventilated COVID-19 patients? For fluid therapy, you have to go towards the restricted side. If you are giving organeless fluid therapy, like if the patient is in shock and you are pumping around 2 liters of the fluid because the guideline has suggested so, then it is very dangerous. So the therapy should be towards the restricted side. Regarding nutrition, in a patient who is having ARDS, you will target protein requirement around 1.2 to 1.5, and the calories should be around 20 to 25 kilocal per kg. That's it.
So we have a question from Motorola. With increased shedding reported on systemic steroids, if we have a patient with obstructive airway disease with COVID suspicion, should we try theophylline? Do not recommend it now in excess of patients. So you see, steroids are also not to be used for every. It is not essential to use steroids for every exacerbation. So the rule of exacerbation is to prevent further exacerbation. So if you have a patient who has a COVID-19 suspect, you may not use steroids initially, but the key remains that you send a sample and collect the report, and then you can better manage these patients if they are negative versus they are positive. So you can optimize their therapy based upon the results. And theophylline can be used if means we all use it for patients who have refractory bronchospasm in which we are not able to ventilate them. We can use theophylline in emergency situations.
There's a question. What is the alternative to HCQ in psoriasis patient in treatment of positive COVID-19 as these drugs flare up the disease? The answer is like if you are using HCQ, it is not the magic or silver bullet that is going to treat the COVID-19 patient. If there is any contraindication, better to avoid it. As such, if you ask about the evidences, then the evidences this says that if you give HCQ and the patient survival will be very good, they are not there at this time. So if there is any contraindication, better not to give it.
How are COVID-19 patients infectious during incubation period when they don't show symptoms? So that is the basic concept of incubation period, that the onset of infection till the clinical manifestation. So that is where the incubation period lies. In this time, the patient has a virus, he is shedding the virus, and the virus is replicating inside the patient. So it is the time they are spreading the disease.
There is a question regarding guidelines for disposal of secretion stool in stable COVID patients.
Regarding disposal of secretions, it has to be with the universal precautions. I don't know. So there have been that the virus shedding may happen in the stool also. So these stable COVID patient secretion should also be handled with supposedly somebody is at home, is producing sputum. Also those secretions should be handled as biohazard only and should be disposed of, because virus will die. It is not that everybody who is at home should be disposing them with so many sophisticated things at home. In hospital, obviously you will treat it as biohazard.
There is a question from Dr. Indru. What are the risks if we use pediatric ventilator for adults? When the risk is like in some pediatric, in majority of the ventilator, there are two options. Whether you and with that option you can make pediatric ventilator or you can convert pediatric ventilator to adult ventilator. The issue is with if the ventilator is not able to deliver adequate amount of tidal volume, then the chances of hypoventilation will be there. So if you go below 4 ml per kg, then the atelectasis will be there. This ultra low tidal volume is not sustainable. That's the problem. Now the question is from Motorola One Power. Any comments on frequency of chest X-rays in a ventilated case of COVID-19?
So chest X-rays are to be done on as needed basis. It is not that everybody who is in ICU on ventilator on ARDS, we should be using the chest X-rays daily. So here comes the role of portable ultrasound or bedside ultrasound, which you can actually use to assess patient tsunami status. But X-rays should be done when you suspect there is a basic or major change in the patient's physiology or ventilatory parameters. So if you want to look at that, then we should do X-rays. Obviously, you have cassettes which are coming inside the ICU. If you do a chest X-ray, there's a lot of movement around the patient. So that should be avoided if it is not necessary.
The question is from 1+6. There are studies indicating myocardial injury, myocarditis turning out to be major cause of mortality. Yes, that's true. In a study done in China, what they found is approximately 35% of the patient, they developed respiratory failure along with myocarditis, and in approximately 7% of the patient, it was myocarditis alone without any respiratory failure. So it may be there. The answer is how to deal with it. If a patient is having myocardial injury and you use high dose of vasopressors, inotropes, these catecholamines will cause further myocardial injury. So better to avoid high doses of inotropic agents. And as such, there is no proven role of steroids in viral myocarditis. The management has to be symptom. You should use echocardiography or non-invasive cardiac output monitor, whether you have LITCO, PICO, to change the SVR, to change the cardiac index, so that you can deal with these patients in a better way.
So any question by Dr. Sundaram, any tests detect at an early phase and take less time for reporting? For now, we don't have anything for like that. But if you see the Gene Expert platform, which is used for TB, now the Cepheid has come up with a Gene Expert like platform for COVID-19 also. So, but that is still just been recommended by FDA. It will take time to reach us. So for now in India, we don't have, like the kit by the AIIMS has also come, but that's also the RT-PCR based kit also. So it will also take the same time. The only difference is that it is Indian made, and it is probably going to reduce the cost of it.
There is a question from Dr. Mithali Patel. I am third year resident doctor of anesthesiology. Since last few days, I am dealing with only emergency patient requiring surgery. From last 4 to 6 days, I am having sore throat and dull headache. Body ache, no fever though. Should I go for COVID-19 testing? Bit confused.
Okay. So, Dr. Mithali, here if you are having, so number one, this question cannot be answered on a distant platform. So it is better that you contact a physician in your hospital wherever you are working. But with whatever history you give, you seem like a candidate for a COVID testing. So whatever center is nearby you, you can go for testing. Keeping in your exposure to the patients with respiratory diseases, and you being a doctor, you are at risk for the disease, so you can get it.
There's a question from Dr. Sundaram. Gene Expert machine for TB. Can we use them for this also with other specific cartridges?
Yes. So the cartridge which is being made for SARS-CoV-2, that is causing the COVID-19 disease, it is the same machine with a different cartridge which can be used. So with that, probably the time to result will reduce to like to Gene Expert a 2-hour time to report. But obviously the important thing here will remain that under the RNTCP, we have got Gene Expert which has been in the entire country. So if we get this kit and the sample quality, that will be very important, because sample collection and transport of sample for these kits will be important. Means you have to maintain the cold chain while you are transporting the sample. So that will be important problems if we get this thing in India as of now, but right now we don't have it in India.
There is a question, role of CRP monitoring in COVID patient. Actually, in COVID patient, there are reports that there is increase in the procalcitonin and CRP. So, like if there is increase in the procalcitonin and increase in the CRP, the management will not change much. The answer is, if the clinical picture is there and the test is positive, you have to treat. CRP may increase because of inflammation, and what we have seen in many patients of viral pneumonia. We have seen procalcitonin of 10, 15, 20. And same with CRP. The management will remain same. Your ventilatory setting, your ICU care, all things will remain same. The only difference is if there is whether there is any supra-added infection or not. If you think that patient is having any supra-added infection in the blood culture or in the endotracheal aspirate, neutrophils are there, you are thinking about some pneumonia, then you will start antibacterial agents, and you should start antibacterial agent as per your own normogram. You should not jump, okay, somebody has said that I will give amoxicillin. It is not like that. Like in our hospital setting, Acinetobacter is quite prevalent. So if there is any ventilator-associated pneumonia, patient is sick, we'll treat that as multi-drug resistant infection in our own setting.
So, question from Motorola Baba: in the absence of proven treatment, should we at all send any lower respiratory samples for retesting if the ventilator is negative on first swab? So it is not required because the infection is likely to start from the upper airway only. So if your patient has come negative and your suspicion is high, you can repeat the sample from upper airway as well as the lower airway, whatever way. If your patient is on ventilator, the respiratory secretions are good enough sample for testing for COVID. There's a question from Dr. Sundaram, rule of NLR. What is NLR?
Neutrophil lymphocyte ratio. Actually, this the role about neutrophil lymphocyte ratio is not well proven. In any form of infection or any form of distress, patient this NLR ratio will increase. So as for this time, we don't know whether we can use it in the diagnosing or in the treatment of COVID patient. As such, in any kind of stress, maybe it is surgical, maybe it is because of trauma, there is increase in the NLR. The question is, any guidelines on eye care in COVID ventilated patient? So if you are having a patient in which you are planning to give deep sedation, say patient is having PO2 FI2 ratio of less than 200, maybe less than 150, and you are planning to give deep sedation or paralysis, better to tape the eyes because you want to prevent exposure keratitis. And if you are proning a patient, then you cover the eyes with a with good amount of cotton so that there is no pressure source or there is no exposure keratitis. There is no role of antibiotic solutions or antibiotic drug in this particular scenario.
So question from Malabar Cancer Center. Sir, how long should a nursing staff caring for COVID-19 patient be quarantined? So not everybody need to be quarantined. So there is a lot of issue that if we put somebody on duty for COVID-19 patient, they should be quarantined for 2 weeks, 3 weeks, should it be done? So it is not required. So you need to, so it is all symptom based and a sample. If you have been tested because of your symptoms and you have been found positive, then only it is required, otherwise it is not. Sir, role of spot test COVID-19 IgM and IgG in diagnosis. So probably we, as far as I know, this test is not yet available with us, but this is likely to come. So it is, but the point is that it is going to delay the diagnosis. It will take at least 7 to 9 days for antibodies to be detected. So using IgM antibodies for COVID-19 virus is there by the point of care test, but we don't have it right now. It will only delay the diagnosis. So probably for surveillance purposes, for epidemiological purposes, the testing for IgG may be useful. We can see it in future, but right now there's nothing like that for us.
There is a question from Pixel 2XL. If a patient has been intubated in emergency casualty, then we want to send for COVID-19 test. Do we need only nasal swabs or endotracheal secretion? In this particular scenario, better you send endotracheal aspirate. The reason is you will be able to get COVID as well as if there is any pneumonia, maybe community acquired pneumonia or maybe some bacterial infection, you will be able to trace out.
Dr. Rajshekar, please ask your question.
Primary health government hospital.
Yes, sir.
Sir, I would like to know when should I refer patient to emergency or a hospital having symptoms? How can I evaluate patient to refer?
Can you please repeat your question?
Hello.
Hello?
Hello.
Hello?
Sir, regarding referral patient having symptoms of coronavirus.
So patients, so first is regarding the testing for coronavirus. So whichever center you are working probably won't be having the facility. So if you have patient who comes in the criteria for testing, which includes symptoms with a history of travel or contact with somebody who has traveled or a healthcare workers with symptoms, should be tested for it. Depending upon hospitalization versus quarantine and at home will depend upon the patient's symptom profile. If patient has mild illness, they can be managed at home. But if they are tachycardic, they are hypoxic, they need to be hospitalized. So your referral will depend upon patient's clinical status regarding respiratory rate and saturation level. For suspects versus positive both.
Sir, submission, sir. Patient came from Mumbai 8 days ago. He went to home isolation. Now he is having throat pain and fever, sir. Cold. Pain, fever, cold. Should we refer patient to the
So patient should be tested, yes.
hospital, or we should isolate another 1 week?
No, so the patient should be tested. If patient has a history,
Yeah, we should.
then yes.
Otherwise, we should treat symptomatic.
Yes.
There is a question from Dr.
Hello.
Yes.
Sorry, actually, patient came 1 week ago. We put him in isolation, home isolation. Now he's having throat pain, cold,
So
and fever.
you can treat him symptomatically, and you should test this patient if he has contact with a positive patient or a suspect. Whenever he has traveled,
Yeah.
whether he traveled to an area where there were positive cases.
Mumbai. He came 1 week ago.
Symptomatic only.
Symptomatic only, sir.
Yes.
Yeah, we should not refer that patient.
So not everybody needs to be referred to a higher center.
Okay, sir. Only if he has direct contact with the person, infected person, then only we shall have to refer, right, sir?
Yes.
Yeah. Okay. Thank you, sir. Thanks. Only a contact untene infected person to refer.
There is a question from Dr. Sundaram. Is there any role of tracheostomy in prolonged ventilation patient? Yes, there is role of tracheostomy. Like if you are ventilating a patient from past 10 days and the condition of the lung is like you think that the patient is going to be on ventilator for another 10, maybe 5 or maybe 12 days. You don't know about it. Then better go for tracheostomy. The question here is that tracheostomy, again, it's a procedure where the aerosol or droplet formation will be very high. So when you are doing tracheostomy, whether it is percutaneous tracheostomy or you are using it or you are doing surgically, at the time of the needle insertion or at the time of the stroma, tracheostoma, you should not ventilate with high volume. Better you give 100% FiO2 for some time, maybe 3 to 4 minutes, 5 minutes, and at the time of the needle insertion, you hold for some time. In these patients, tracheostomy must be done, or any kind of airway handling should be done by some experienced person. It should not be done in amateur hands. Again, like in cases of intubation, there is risk of droplet and aerosol. Same is with tracheostomy here.
So the question from Lenovo, a few reports suggesting that sudden anosmia or loss of taste can be symptom coming earlier than other symptoms you are using. So it's an epidemiological data, means you, whatever has been reported earlier were the premium symptoms of fever, cough and shortness of breath. anosmia has been reported, and by the ENT societies, it shows that it may come earlier, but it is very early for us to say that it can be used as a screening for COVID-19 disease or something till we have more data to tell that it is a very common symptom.
There is a question from Christy. What are the poor prognosticating signs of COVID-19 patients on ventilator? It is same that of any ARDS, I think. And like the myocardial injury is more. If the patient is having myocardial injury, ejection fraction is less, and patient is in shock. And in ARDS, if hypercapnia is there after use of all ventilatory setting, if hypercapnia is there, plateau pressures are high, mechanics are bad, they are bad prognostic factors, poor prognosticating factors. And also the comorbidness, if patient is having coronary artery disease on the top of diabetes, hypertension, maybe COPD, age is more than 60, maybe 70, these are poor prognosticating features.
So, question from Suresh Babu. Is it true that infants are immune to COVID-19? So, we have had reports of infants having COVID disease as well. So, it is not that children or infants are immune. The probably reported less incidence in children from China was related that they closed school very early in the onset of their epidemic. So children were actually less exposed to the virus. So, there were less disease in children. Then we have a question follow up to the previous question on COVID-19 testing on previously intubated patient. Do we disconnect the ventilatory circuit for aspirate if closed suction is not available? So closed suction, if it is not available, then anyway you'll be opening the circuit and generating the aerosols for any suction procedure which will be happening. So if you are not able to use a closed suction, then you are at risk for generation of aerosols. So you can collect the AT aspirate whatever way you can. But if you are not using, you'll anyway be suctioning the patient with an open circuit. So question from Pont Helek. Gold has released a statement regarding increased susceptibility to COPD patients for COVID-19. Your opinions regarding management of mild exacerbations of and warranting hospital visit. Will you suggest COVID testing? So for patients with previously having respiratory illness, obviously they are at higher risk, and it has been told by Gold also. But the testing will still remain with the same testing principle. If they have a contact, or a travel visit or a healthcare worker, they should be tested. So testing is still restricted, keeping the resources and the field in mind. So they should not everybody with the COPD exacerbation without any other history should be tested. There is a question from Sanabe. What prophylaxis should be started for doctors working in emergency isolation? So if you are in working in emergency isolation in which you are dealing with COVID-19, ICMR recommends using hydroxychloroquine prophylaxis. It should be on day 1 2 doses and then weekly for 7 weeks.
There is a question from Dr. Sarang Patil. How to clean the bronchoscope if used to intubation in difficult to intubate corona patient? So the management will be same as you are using as you are doing in any other patient. You will clean the bronchoscope with water. You will use the brush to clean the internal surface, and you will dip it inside X for 20 minutes. After then, you will flush it out again with water, and then you can reuse it. The procedure is same as you are using for any other patient.
I request everyone to please feel free to ask questions if you have any.
So this session will last at 13, that is 1 p.m. So we are having still 10 minutes. So you can raise your questions.
So there is a question from Dr. Revati. One patient with history of shortness of breath and sore throat without fever for past 2 days, who has been home quarantined, has a travel history from Andhra. Clinically, no evident dyspnea. Is there panic attack associated quarantine? And will be candidate to be tested. So if he has been exposed to somebody who has traveled to the affected areas, then only he becomes a candidate for testing. The home quarantine, if there is it panic attack associated quarantine? So there should be, so number one thing is there should be no fear in testing or getting home quarantine. That's the first question. That if you develop symptoms, you are supposed to reach the hospitals. Otherwise, you can stay at home. But he does not fulfill the criteria for to be tested unless his symptoms worsen, means he develops respiratory, severe acute respiratory illness, or he has a history of contact with somebody who has been traveled to the affected. So we all need to alleviate this fear from the public that everybody who gets COVID is going to get bad illness, if they are not going to survive. What are the, so these myths from the community should go away.
As per now, the mortality in India is roughly around 2%, and the majority of cases were having some comorbid illness, and the age was towards the outside of 60 or 70. So, as such, it is very contagious. The mortality is around 2%. The question is, if we don't test symptomatic without contact history, how will we know about community spread?
So this question is probably not the best for us to answer. It is by the ICMR that how can we actually improve our testing facilities, but for now it remains the same. Obviously, ICMR has random community sampling. ICMR has been doing, and whatever results they've got, they have told that there is no community spread happening as of now. So ICMR is doing random community sampling rather than so that actually tells that there is no, but we don't have any definite data for that. As of now,
there is a question from Pixel 2XL. What is your opinion on using one ventilator for 2 patients using a splitter? Will adequate volumes and pressure and be assured to both patients? Will setting be double that of a single patient? The answer is we don't know. We have not used it yet. And at this time, actually, it is very difficult to use in patients who are relatively better, who don't have COVID, and if we don't have a condition of resource limitation, it is difficult to use. If in future, if we use it, we'll share the experience with you.
Question from Pankaj.
No, we can take a question from Galaxy Note 9 first. There's an audio question there.
Okay.
Yeah, please, Galaxy Note 9, please ask your question. Galaxy Note 9, please ask your question.
Galaxy Note 9 isn't responding, so let's just move ahead.
Please take a last chat question, then we. Galaxy Note 9, can you please ask your question?
Not knowingly seeing a COVID-19 patient, so shall I isolate myself from my elderly and kids, or should I wait and once I'm posted in the COVID-19 ICU, only then should I separate? How to protect my elderly and kids?
So you can protect your elderly and kids by using the personal protective equipments as required and as in the guidelines for seeing the patients in ICU versus the emergency versus the screening area. Use the appropriate personal protective equipment. If you have any symptoms, get yourself tested. If you don't have any symptoms, you need to use the PPEs and repeat hand washing once you go home. Don't take the hospital clothes home. Try to have a shower once you reach home. without touching things. So these are some of the precautions we all as medical health professionals can take, that we don't spread the infection to our family. We need to just take some precautions. We don't touch here and there. Once we reach home, we should clean our hands, wash face, with whatever way. But the important thing that your fomite should not be spreading infections. Your hand should not be spreading infections.
Thank you, sir.
There is a question from 1+7. Yesterday, a patient with fever was operated for emergency cesarean. She later developed respiratory distress and needed oxygen therapy. Does she need to be tested? The answer is, in this particular scenario, if there is any contact history or the patient is towards the high side of the risk, she should be evaluated. There is one question from Christy. So the patient who died due to COVID-19 in Madurai, Tamil Nadu, did not have a travel history or contact with a positive case, but he had come in contact with friends who had traveled history, but were not symptomatic. Is this an example of community spread?
So community spread is happening when you are not able to trace the person from where the infection has come. If you are still able to trace the contact from where the infection has come, it's still not considered the community spread which is happening. So community spread is when you are not able to trace the source of infection. So we have had a few questions of somebody asked that any specific instructions for follow-up patients with chronic lung disease to prevent COVID-19. So basic instructions remain the same. The follow-up patients for chronic lung disease, they should not be moving out. They should take all the precautions required for prevention of infection. They should not be making unnecessary hospital or doctor visits.
There is a question from Dr. Sarang Patil. Should a sputum positive pulmonary tuberculosis patient on ATT considered as a high risk patient and tested for COVID or given only symptomatic treatment? There is no evidence which suggests that if you have tuberculosis, the risk of COVID will be there. So at this time, there is no need to go for testing or no need to go for symptomatic treatment for COVID. There is another question from Anu. The question is, do you suggest 14 days quarantine for healthcare worker caring for COVID positive cases?
No, it is not totally recommended that they should be quarantined for 15 days.
There is a question from Acer. Do you think India will have alarming figures like in Italy, USA? If yes, how soon? So as per AIIMS study, they are suggesting that chances of patient coming or visiting ICU will increase. And the range is quite high. It can vary from thousands to lakhs. So we don't know. Regarding time, also, we don't know. This lockdown can prevent the transmission of infection and can flatten the curve. Let's hope for the best. At this time, we don't know within how many days our ICU resources will be full or depleted.
But the only thing which is important in here for all of us is that we need to take measures to prevent this spread of infection, which includes lockdown, which has been conducted by the government, and then we have to use hand hygiene as the PPEs as and when required.
There is a question from 1+7. What are recommendations for doctors with asthma working in anesthesia intensive care? Actually, there are no particular recommendations for doctors with asthma. You continue your therapy, what you are taking, and as such, the risk of getting infection will be there if you are working in high risk areas. So you have to take all the measures to prevent infection to yourself.
So there is a question from Anu. Do you suggest segregating healthcare workers caring for COVID positive in separate facility? So it is not a recommendation, but what most hospitals are doing, that they have separate teams which would be caring for patients with COVID, but it is not required. They need to stay there. They can go home. If they are using all the PPEs and the infection control practices, they all can go back home after their shifts are over. There is nothing like that they need to shift in a separate facility. So it is important that we should not become the chain of transmission. If we don't, we will become if we don't use the PPEs and the hygiene practices as well.
There's another question from Anu. how are you planning for isolation ward, and how many hours at a stretch for healthcare worker? For a healthcare worker, the time is in between 4 to 6 hours. If you stretch it more than 6 hours, it is very difficult to work with full PPE on. So it is in between 4 to 6 hours with all like clinical over and all. There is another question.
Any risk of COVID treated patients using public toilets? So it is remains the same, that if they cough, they will spread the infection as a droplet on the surfaces. So if you maintain the social distance, do not touch unnecessary areas. If you are touching around, then you will have the infection on your hands and you can spread it. So it is about the social distancing and hand hygiene which will prevent all these issues.
There is also one few report about the transmission.
India is a country where we have a lot of elderly people with comorbidities. Hello?
Yes, you are audible.
Here we have a lot of elderly people with comorbidities. Considering if these people, if a lot of elderly people are occupying the ventilator beds, and we have and we have a lot of and if we have a lot of young people who are requiring ventilator and who are expected to improve if put on ventilator, do you think that if you frame some guidelines on removing those people, those elderly people out of ventilator, and provide the youngsters the ventilators, so that the chances of so that because they have a lot of chances to improve?
Yes, we do understand your concern.
Do we really have to think about it? Do we have to frame a criteria to remove the ventilator support from the elderly people? Because they are not expected to, not everyone, but if we feel like they are not going to come out of it just occupying the ventilator in the ICU for a long time, do you think that we'll have to frame any criteria for that?
We understand your concern. Your concern is that if we put lots of old patients on ventilator, then what will happen to the younger patient? And can we withdraw the ventilator therapy? But as per this time, we don't have any law, any recommendation which suggests that we should remove the ventilator therapy. It's kind of a crime if we do it right now. Better let it come. If you think you are having 4 ventilators and there are 40 patients, then at that time you have to do triage. But at this time, if you say that, okay, if a patient is aging more than 60 years and patient is on ventilator, another fellow come who is of 20 years, I will remove the ventilator, change the circuit and put it to some other patient, that is not going to work at this time. Maybe once we are in the full spectrum of COVID disease, maybe after 2 months or 1 month, we don't know, then we can go for triage. And in triage, if the age is more than, like what the people in Italy are doing, if the patient's age is more than 80, they are not intubating the trachea, they are just putting NIV and giving comfort care. At this time, there are no recommendation. At this time, we cannot comment upon it. But withdrawal of therapy is a serious concern. At this time, our law is against it.
Okay, thank you.
There's a question from Esther. With hot summers starting in India, do you think it will modify the course of this pandemic? What is
So it is very difficult to comment on this. Obviously, we expect that there will be some degree of decrease in the transmission. But you see, we have a flu season which happens in summers also. So we can't really predict how will the pandemic course will be there once the temperature rises. And we don't know whether it will be the temperature or whether it will be the effect of lockdown or the preventive measures which we have started right now. What is the reason if we don't reach the highest stage of the pandemic? So we all believe that we will be able to contain it with the current measures, and we need to work towards it.
Thanks a lot for your questions, and you people were very enthusiastic. Thanks a lot. We are finishing this session at this time, and on Saturday, you may again join at 10:30. If we have new, because every day new guidelines are coming, new data is there in the literature. We can discuss few more questions.
Yeah,
so
so
see you
one
on Saturday,
last
10:30.
announcement from my end.
Yes, yes.
I have like again posted a link for the feedback form. I've seen like not many people have filled it. I would request everyone before leaving kindly click on the link and fill it up. It will only take 2 minutes at max to fill up the form, and it will also help us improve ourselves in the future sessions as well, be it the next upcoming session on Saturday. Thank you.
So please, I request you to fill the feedback form. It will help us to raise the, like, to answer the question and to prepare our facilities better. So please fill the forms, feedback forms. Thank you. Thanks a lot.